Good evening, everyone, and welcome to our webinar update on heart failure, case studies navigating the new therapeutic landscape. I'd like to start tonight's meeting by acknowledging the lands we're meeting on as Wiradjuri land. I'd like to acknowledge that we work on the traditional lands of many Aboriginal clans and nations and pay respect to elders past, present and emerging, and acknowledge their continuing connection to land, water and culture, and ongoing contribution to help shape the life of the communities in which we all work and live. We're committed to working in the spirit of partnership and collaboration with our region's Aboriginal communities and peoples to improve their health, emotional and social wellbeing. I warmly welcome Aboriginal and Torres Strait Islander Australians who are present in this meeting tonight. A few housekeeping points. If you can't see your control panel, just click on the small orange arrow that's at the top right of your screen and that should open up your control panel for you. Everyone's on mute automatically to optimise the sound. So if you have questions, can you please type them into the questions box? Anyone phoning in tonight, can you please email your full name for your record of attendance to cpd@western-new-south-wales-phn.org.au, and we're recording tonight's webinar. Tonight we're very lucky to have with us Dr. Alex Elder, who's an interventional cardiologist who works at the Orange Health Service. He completed his cardiology training at RPA prior to undertaking a fellowship in interventional cardiology and further specialist qualifications in echocardiography. Thanks so much for joining us tonight, Alex. Learning outcomes are to identify different causes of heart failure, describe new therapies, both pharmaceutical and device and operative, for the management of heart failure, and to relate different types of cardiomyopathy to patient journeys and outcomes. We might just hand over to Alex to start the show.
Well, thanks very much, Liz. So I'm just going to open up the talk on my screen now. Okay. Just going to compress some of these sidebars here. Great. Okay. Can everyone see that there on the screen? Is that working, Liz?
Looks good, Alex. Yep.
Terrific. Well, thanks very much for inviting me to come and give this talk today. I think I came here and presented to your meeting when I first moved out to Orange about 3 years ago, which seems like only a few days ago now, but time has flown. So the talk today is on updates on heart failure, case studies navigating the new therapeutic landscape. And I thought I'd present two cases which kind of illustrate the different therapies that are available to us now for the management of heart failure and how that affects patient journeys and outcomes. So just a little bit on the prevalence of heart failure, which continues to rise in Australia, and the numbers are quite astounding. So 500,000 Australians are affected by heart failure, with 67,000 new cases per annum. This accounts for 158,000 hospital admissions, and as you can see, the number of days that patients spend in hospital is quite a lot, because that's 1.1 million hospital days from those 158,000 admissions. There are 61,000 heart failure related deaths per year, at a very large cost to the health budget. And the case numbers are only increasing, and it's predicted that by 2025, the number of Australians living with heart failure will be up to 657,000. So what's the prognosis for these patients? Well, it's pretty grim at the moment. Even with current heart failure standard of care, 9 out of 10 patients are symptomatic. And 5 out of 10 patients will die within the first 5 years after diagnosis. And what you can see, the breakdown here, is that each heart failure hospitalisation entails a worse prognosis, obviously. So after the first hospitalisation, the mean survival is only 2.6 years, and that deteriorates with repeated presentations. So with that kind of grim background to the burden of disease, what therapies do have mortality benefit in heart failure? And the reason I wanted to give the talk on heart failure today is because I think there are a lot of great new therapies available to us. and a lot of these therapies have come up over the last 10 to 20 years. So this is a little slide that I put together showing the timeline of some of these heart failure therapies and their development. It's dating back here to 1987 when enalapril was published in the NEJM as one of the first heart failure therapies to have a mortality benefit. And we know that the ACE inhibitors and also the angiotensin receptor blockers are cornerstones to the treatment of heart failure with reduced ejection fraction. Then in the 1990s, some of the beta blockers were shown to have mortality benefits for heart failure. And so the Lancet in 1999 published metoprolol succinate, which is the long-acting form of metoprolol. Bisoprolol also was found to have mortality benefit that year. And then in 2001, the Copernicus study was published in NEJM, which showed that carvedilol also had a mortality benefit for patients with heart failure with reduced ejection fraction. And so those three studies are really influential in the choice of beta blockers that we use for the management of heart failure. And you're probably aware that there are certain beta blockers that we prefer, and it's those three, plus minus nebivolol, which has slightly less evidence behind it, but is probably equally effective. And they would be the four heart failure specific beta blockers that we would use as our go-to agents. The Ardactone evaluation study came out in NEJM in 1999, showing a mortality benefit for spironolactone, and then subsequently another study showed for eplerenone. In 2002, we saw the first of the device trials come out, and that was the MADIT-2 trial, published in NEJM, showing a mortality benefit for patients with an ischemic cardiomyopathy who had an AICD implanted. And that was quite influential, and it's really changed the management of ischemic cardiomyopathy. And most of our patients with severe ischemic cardiomyopathy would have a defibrillator implanted. The CHARM study in Lancet in 2003 showed the angiotensin receptor blockers to be a good alternative to ACE inhibitors for patients with heart failure with reduced ejection fraction. And then we saw some more device therapy trials come out, and I'll go into these a little bit more in my talk today. But the CARE HF and the MADIT CRT were both trials looking at the use of cardiac resynchronization therapy. Then more recently, Ivabradine, then Entresto, have been shown to be drugs which are very effective for heart failure with reduced ejection fraction. Castle AF trial, which we'll again discuss today in more detail later in the talk. And the most recent one was the Dapagliflozin trial looking at SGLT2 inhibitors. So that's kind of the landscape, and it's how it's changed over the last 20 to 30 years. And I think we'll go on to go through some cases now to just show you how we navigate this therapeutic landscape, and then delve into some of those papers a little bit more later in the talk. So I've just got two cases to show today, both with some really interesting imaging. And the first case is Mr. PW, who was a 39-year-old school teacher who presented to Orange Emergency Department in November of last year. He had a 3-week history of breathlessness on exertion. He reported leg swelling, breathlessness at night time. He said, these are quotes from the ED notes, waking up in the middle of the night breathless, and he had abdominal discomfort. He'd been given a course of prednisone for 3 days prior because he has a history of asthma. It was found no improvement from the prednisone. So the other comorbidities were depression, anxiety. He had an elevated BMI and probable undiagnosed sleep apnea. His prior medications were escitalopram, serotype, and salbutamol for his asthma. So Mr. PW in ED had a blood pressure of 110/70. He was tachycardic. He was saturating at 100% on room air and afebrile. His cardiac exam identified dual heart sounds with no murmurs. He had decreased air entry at the lung bases and pitting edema to the knees. And he was tender in the right upper quadrant on abdominal examination. Now, this is one of the downfalls of having an online presentation, because I can't pinpoint someone in the audience to interpret the ECG or the X-ray. But these are the investigations that he had in ED. So an ECG on the left there, which has been labelled by the ECG machine as atrial fibrillation, but you can quite clearly see P waves, and it's a sinus tachycardia. The cardiac axis appears normal because it's up in 1, up in 2. There's poor R wave progression because the RS transition point is lead 5, where it should be lead V3 or V4. There were no acute ischemic changes there. So the predominant findings of that ECG would be sinus tachycardia. And then the chest X-ray on the right of the screen showing an enlarged heart with some pulmonary venous congestion. No significant pleural effusions, but a picture which would be concerning for congestive cardiac failure. So Mr. PW went on to have an echocardiogram, and this is the echocardiogram that was performed on the day of his admission. And we can see that his left ventricle here, this is the parasternal long axis view of the heart with the, I don't know if you can see my arrow, I hope you can, but the left ventricle up here with the mitral valve here, and then the aortic valve. And I guess the salient point to see here is that the left ventricle is not contracting very well at all. And this is the apical 4-chamber view with the left ventricle at the right of the screen, the right ventricle on the left of the screen. This is the mitral valve here. And then another view, which is the apical 2-chamber view. And the important finding here is that the left ventricle is so poorly contracting that there's actually a left ventricle apical thrombus which is formed, and you can see that echo-dense material at the apex of the left ventricle, which shouldn't be there, and that's an indication that there's very poor flow and stasis of blood, which is forming a left ventricular thrombus. So this ventricle probably has an ejection fraction of about 15, maybe 20% at most. It's globally impaired. It's a little bit dilated. And the next picture here shows there's moderate mitral incompetence, and the etiology of that mitral incompetence is what we call functional or secondary mitral incompetence, and that's because the mitral annulus has been dilated by the dilated left ventricle, and we're getting poor coaptation of the mitral leaflets in the center, resulting in a central mitral incompetence jet. So Mr. PW was admitted to coronary care at Orange Hospital. As he was fluid overloaded, we commenced him on IV furosemide, and he was put on cardiac telemetry. Whilst on cardiac telemetry, it was noted that he was having runs of non-sustained VT, which is obviously a risk of someone with a severely impaired ventricle. And so given that we were seeing that non-sustained VT, we wanted to make it go away. We thought we would give him a small dose of a cardioselective beta blocker. So he had initially 3.125 milligrams of carvedilol, and that seemed to go okay. So we thought we'd increase it and give him a little bit more at 6.25 milligrams. Sounded like a good idea at the time. About 2 hours later, there was a MET call to coronary care, and we all rushed down from the cath lab, and Mr. PW's blood pressure was unrecordable. He looked diaphoretic, tachypneic, and tachycardic. He had a weak peripheral pulse, but was GCS 15, and his VBG showed a metabolic acidosis. So what we've done is we have given a chap with a severely impaired left ventricle a beta blocker, and we've precipitated cardiogenic shock. So we had to immediately start some resuscitation. So he got some intravenous fluids and IV metaraminol as temporizing measures. He was transferred across to the intensive care unit where some central lines were inserted. We put him on a dobutamine infusion, which is a beta agonist and counterbalances the effect of the beta blocker that we had given him earlier in the day. And with this management, he settled, his blood pressure improved, he became warmer peripherally and felt a lot better. At this point, we thought we would cut our losses and send him to RPA, because we've got a chap here who's got a severely impaired left ventricle who has not tolerated introduction of heart failure therapy. And we thought that he would be better off in a center with mechanical circulatory support, because these patients with severely impaired ventricles can really go down the gurgler very quickly. And I think we really dodged a bullet with the initial instigation of beta blockers there, and we thought the next time they were introduced probably should be in a center with a little bit more support. So he was medically retrieved down to RPA, and at RPA underwent the usual investigations that we would perform for anyone with a newly diagnosed severe cardiomyopathy. So those investigations, firstly is a coronary angiogram. So we're looking for coronary artery disease as a precipitant for his cardiomyopathy. Mr. PW's coronary angiogram showed normal coronary arteries, which is probably what you would expect in a 38-year-old man without any traditional cardiovascular risk factors. More and more these days, we're using cardiac MRI as a way of assessing cardiomyopathy. It allows us to look for any infiltrative cardiomyopathies like sarcoidosis and amyloidosis. And it gives us an idea about LV function, RV function, valvular function, looks for thrombus within the left ventricle and right ventricle. So it's a very good study, very useful, and really becoming a cornerstone of the workup of these patients with severe cardiomyopathy. So he had a cardiac MRI at RPA, which showed severely dilated left ventricle. The ejection fraction was similar to what we calculated here in orange. The findings were reported to be consistent with the dilated cardiomyopathy, in that there was no scar suggestive of previous myocardial infarction and no infiltrative cardiomyopathy. We usually send off a panel of viral serology looking for any causative agents which may have contributed to the cardiomyopathy. We often check EBV, CMV, Coxsackie, parvovirus, HIV, COVID-19 is now part of that workup. And we often do a respiratory swab for respiratory pathogens as well. They've all come back negative. He was commenced on IV diuresis, and diarrhea is down to a dry weight. And then whilst at RPA, heart failure therapy was instigated. So again, using carvedilol, a heart failure approved beta blocker, and it would have been started at 3.125 milligrams twice daily and very gradually up titrated. Entresto was used, which is the combination of sacubitril and valsartan. They would have started at a starting dose of 24/26 milligrams BD and up titrated to 49/51. Given the finding of the LV apical thrombus, he was commenced on a NOAC, although this would not be PBS approved for this indication, so they may have fibbed to get that one through. You could use warfarin in that setting, and that would be a very reasonable alternative to a NOAC for the treatment of an LV thrombus. And he was discharged home on oral furosemide at a dose of 40 milligrams BD. So he was discharged on the 4th of the 12th, a week or so after his initial presentation. And as often is the case with these patients with severe cardiomyopathy, they have multiple presentations. So Mr. PW was shortly back in orange ED with increasing weight and lower limb edema. He was put back on intravenous furosemide and commenced on spironolactone, which we up titrated to a dose of 25 milligrams daily. As an outpatient, we have subsequently commenced him on Ivabradine, which we use for patients who have an elevated heart rate greater than 77 beats per minute at rest, despite maximally tolerated beta blockade. And so he was started on Ivabradine, and that could be up titrated further. It goes to a maximum dose of 7.5 BD. The things that we're going to consider at follow-up, so he was due to follow up last month, but had to cancel because of illness in the family, but he's due to come back next week, and the things that I'll be thinking about is should we put him on an SGLT2 inhibitor? And also I'll be thinking about device therapy and whether this patient would benefit from cardiac resynchronization therapy or an implantable cardiac defibrillator. So just to go through this case and the medication landscape that we kind of encountered here. So I think the new therapies that we should have a look at are Entresto, Ivabradine, SGLT2 inhibitors, and then device therapy for heart failure. So I'll go through those one by one. So Entresto, first and foremost, it's been around for a little bit of time now. So the pivotal trial on Entresto was published in the New England Journal back in 2014, and that was the Paradigm HF trial. As you probably know, it's a combination of a neprilysin inhibitor plus an angiotensin receptor blocker. And both these agents have benefits by increasing vasodilation, decreasing sympathetic nervous system activity, increasing the parasympathetic nervous system activity. They reduced cardiac fibrosis and reduced the risk of arrhythmia. So the pivotal trial for Entresto, as I mentioned, was the Paradigm HF trial, which was 8,442 adult patients with NYHA class 2 to 4 heart failure and an ejection fraction of less than 40%. The intervention was randomized, patients randomized to Entresto. There was an initial kind of run-in period there where they were shown to be able to tolerate the medication, and then they were randomized to either Entresto or enalapril. The Entresto dose was 49/51 and then up titrated to the max dose, which is 97/103. The primary outcome of the study was a composite of cardiovascular death or heart failure hospitalization. And you'll see across all the heart failure trials these days, that's the primary outcome that everyone's reporting. And really the inclusion of heart failure hospitalization is what gets a lot of these trials across the line in terms of getting a positive result. So the result of the Paradigm HF trial did show that Entresto had a lower rate of the primary outcome with a hazard ratio of 0.8 and a confidence interval that didn't cross 1. So what I think you should know about Entresto is that it does have slightly higher rates of hypotension than ACE inhibitors. Sometimes what we'll do, when we're trying to get patients onto Entresto is we'll start them on valsartan at a dose of 20 milligrams BD. And if they tolerate the valsartan at 20 milligrams BD, we can swap them on to the valsartan sacubitril combination. And that's one way we're getting patients onto this medication in hospital. The Entresto arm of the Paradigm HF trial had lower rates of renal impairment and lower rates of hyperkalemia when compared to enalapril, so I guess that's important. And the way we manage Entresto as an outpatient is we gradually increase it at 2 to 4 weekly intervals up to the maximum tolerated dose. And certainly, in patients that you're following up as a GP, if you can up titrate their heart failure therapy at that kind of interval, that's greatly appreciated, because we know that the best outcome for our patients is when we get them onto the maximally tolerated doses of these medications. So the next medication that I thought we could discuss is Ivabradine. Now, Ivabradine I don't think has had the same traction as Entresto in the heart failure landscape, and I suspect that you're probably not seeing as many of your patients with heart failure on Ivabradine. And I think that's because the indications for it are somewhat limited, but I think it is an important drug to know about as well. So Ivabradine blocks the IF funny channels of the sinoatrial node, and it results in a lower heart rate. It doesn't have any other appreciable cardiovascular effects, so it doesn't tend to drop blood pressure. It doesn't act as a peripheral vasodilator, has no positive or negative inotropic effects, just slows heart rate down. The pivotal trial for Ivabradine was the SHIFT trial, which came out in Lancet back in 2010. And that was a trial looking at 6,500 patients with symptomatic heart failure, again, with an ejection fraction of less than 35%. They were in sinus rhythm with a heart rate of greater than 70 beats per minute and had been admitted to hospital within the previous year with an exacerbation of heart failure, and were already on max tolerated doses of beta blockers. And the intervention in this trial was giving the patients Ivabradine at a starting dose of 2.5 milligrams twice daily, and it was gradually up titrated to 7.5 milligrams twice daily. The primary outcome, as usual, is a composite of cardiovascular death or heart failure hospitalization, and Ivabradine was shown to have a lower rate with a hazard ratio of 0.82. So what you should know about Ivabradine, its PBS approval is somewhat limited, and the PBS listing for Ivabradine at present is for patients in chronic heart failure with a resting heart rate of greater than 77 beats per minute. And the 77 came because of a subgroup analysis in the SHIFT trial, which seemed to suggest that that was the group that really got the best bang for their buck by using Ivabradine. We titrate the dose, aiming to achieve a resting heart rate of around 60 beats per minute. And it's reported that it can cause visual changes. I haven't seen that, but apparently they spontaneously resolve. So that's a bit about Ivabradine. We did use it in the case of Mr. PW. He's on 2.5 milligrams BD, and at follow-up it'll be important to see what his resting heart rate is, because he's on a maximum dose of carvedilol, And if his resting heart rate's greater than 60, I'll probably increase the Ivabradine up to 5 BD. So the next drug is Dapagliflozin, and I feel like really you should probably teach me a bit more about Dapagliflozin, because I'm sure you're all using Dapagliflozin more than I am at present. As you know, Dapagliflozin is an SGLT2 inhibitor, and the pivotal trial for Dapagliflozin in the heart arena was the Dapa-HF trial, which was published in NEJM in 2019. And this trial was one where 4,744 patients with NYHA class 2 to 4 heart failure, ejection fraction of less than 40%, were randomly assigned to either Dapagliflozin or placebo. And importantly in this trial, it included both patients with and without type 2 diabetes. The primary outcome of the trial was a composite of worsening heart failure or cardiovascular death. And the result, over a median follow-up of 18.2 months, the primary outcome occurred in 16% of patients who were allocated to the Dapagliflozin arm and 21% in the placebo, with a significantly different difference with a hazard ratio of 0.82. So this trial was actually stopped early because of the positive effect of Dapagliflozin on these patients. And the trial was actually published at the European Society of Cardiology meeting, which was held in Paris in 2019, and I was lucky enough to attend that meeting. And I've got to say, it was one of the funnier meetings that I've been to, because these cardiovascular meetings have like 50,000 cardiologists there, and these ginormous halls. And this was the key paper of the 2019 ESC meeting, and it was quite funny when they presented the findings. So everyone was, very pleased to see that positive effect, the hazard ratio of 0.82. But importantly, Dapagliflozin was shown to significantly reduce the risk of the primary endpoint in both patients with and without type 2 diabetes. And there was literally people standing up on their chairs and wolf whistling at that outcome, which was amazing for a cardiovascular trial. So what you should know about Dapagliflozin in the heart failure arena is that it's not currently listed for non-diabetic patients, but is TGA approved. And I'm told to expect that sometime in 2022, there should be a PBS listing for Dapagliflozin for non-diabetic patients for the treatment of heart failure with reduced ejection fraction. At present, the company that makes Dapagliflozin has an early access program for non-diabetic patients, and we can enroll up to 20 patients each for that early access program. But by next year, we'll be seeing more and more patients being prescribed Dapagliflozin, whether or not they have diabetes. And then it becomes a question of, is Dapagliflozin a heart failure drug or is it a diabetes drug? And there's arguments to and fro there. So the next therapy that I thought we could talk about for this trial, for this patient, is device therapy. And the trial that I thought I would mention to you all is the CARE-HF trial, which was the pivotal trial for really showing the mortality and heart failure hospitalization benefit for cardiac resynchronization in heart failure. So just before I go into that trial, just to remind everyone what cardiac resynchronization therapy involves, the picture on the right of the screen here shows a pacemaker sitting in the left prepectoral position with three leads coming from the pacemaker going through the SVC down to the heart. And those three leads are the conventional two leads. So we've got a right atrial lead and a right ventricular lead. And the additional lead, the third lead that makes it a cardiac resynchronization pacemaker, is the coronary sinus lead. And you can see that lead entering the coronary sinus from the right atrium. And the coronary sinus is a really useful structure in the heart because obviously it returns all the venous blood from the coronary circulation back to the right atrium. But from a device therapy point of view, the coronary sinus is really useful because it runs around the mitral annulus down towards the left ventricular apex. And we can put a lead into that coronary sinus and attach it there, and that can pace then the left ventricle and allows us to get a more physiological pacing of the heart. So, traditionally with a single lead pacemaker in the right ventricle or a dual lead pacemaker where you have a right atrial and right ventricular lead, if you're pacing in the right ventricle, you'll get dysynchrony. You'll get what appears to be a left bundle branch block on the ECG, and the heart will contract first in the right ventricle, then second in the left ventricle. And that's thought to contribute to LV dysfunction. And we know that some patients with heart failure have dysynchrony. And the thought is here in this field is that if you can correct that dysynchrony by pacing the right ventricle and left ventricle at the same time, you'll probably improve their heart failure. And that's what the CARE HF trial looked at. So this trial enrolled 813 patients with NYHA class 3 to 4 heart failure, so more severe heart failure. Ejection fraction had to be less than 35%. The intervention was cardiac resynchronization therapy, and the comparator was optimal medical therapy alone. And the primary outcome of this trial was time to death from any cause or heart failure hospitalization. And the trial showed a significant benefit of cardiac resynchronization therapy in this patient population with a hazard ratio of 0.64. Subsequent to the CARE HF trial, there have been a number of trials that have looked at cardiac resynchronization therapy. And the current guidelines on who we use cardiac resynchronization therapy for really favor people with impaired ventricles, so ejection fractions of less than 35%, preferably in sinus rhythm because we want them to be paced a lot of the time, and that helps with our pacing. And they have to have a bundle branch block. And the trials, when you break down these trials like the CARE HF trial and a couple of others which looked into these devices, they really found that the patients who benefited from cardiac resynchronization therapy were not patients with right bundle branch block, but were patients with left bundle branch block. And so that's replicated in the current guidelines, both from the American Cardiac Society as well as from the European Cardiac Society. So you have to have a left bundle branch block, preferably with a QRS in excess of 150 milliseconds, but you could consider it for patients with QRSs 120 to 150 milliseconds. With these devices, there's also a question about whether you should make them CRT pacemakers or CRT defibrillators. And the only difference being that a defibrillator would have a shocking electrode in the RV, whereas a pacemaker just has the ability to pace the RV. And if you look at who's indicated for a CRT pacemaker, ejection fraction of less than 35%, and NYHA heart failure class, well, now it's class 2 to 4. There are also people who would benefit from a defibrillator. So most of the time when we're putting in a CRT, it'll be a CRT defibrillator. And I guess, when you see the reports coming back from these patients, pacemakers in the defibrillator clinic or the pacemaker clinic, one of the numbers that will be quoted in that pacemaker report is the percentage of pacing. Now, traditionally with the pacemaker pacing in the right ventricle or the right atrium, we want to minimize pacing because we know that the heart's happier when it's got its own intrinsic rhythm. With cardiac resynchronization therapy, it's actually the opposite, because what we're trying to do is get around the dysynchrony, get around the bundle branch blocks, and improve the cardiac synchronization by pacing both in the left ventricle and the right ventricle at the same time. So we're actually aiming for these patients to have as high a pacing percentage as possible. So ideally greater than 95%. So that's one of the numbers that we look at when these pacemakers are checked in the pacemaker clinics. So that's the first case that I wanted to present. So the second case is a little bit shorter, but equally interesting and raises some other issues. So the next patient is Mr. JC. I've chosen another young patient, this time a 48-year-old farmer from Cowra, and he looks like a very healthy 48-year-old farmer. He's slim. His past medical history is only significant for ankylosing spondylitis, and he was diagnosed with atrial fibrillation about 9 months ago when he was down visiting some family on the south coast. At that stage, he was started on apixaban and metoprolol, But for some reason, the patient stopped at 6 weeks prior to this presentation. And I think it might have been around harvest time and things just got busy and he stopped his medications. And 6 weeks after stopping them, he presented to Cowra Hospital with breathlessness and palpitations. So this was his assessment in Cowra ED. He was tachycardic with a heart rate of 172, normotensive, again, normal respirate rate and saturations. And the examination findings in power charts said that he had decreased air entry at the lung bases. His ECG on the left of the screen here shows a narrow complex tachycardia, which appears irregular at a rate of 145 beats per minute. The cardiac axis is normal, and this is AF with rapid ventricular rate. I would say that the QRS voltages are a little low in the limb leads. The chest X-ray on the right of the screen again shows an enlarged heart. There's some pulmonary venous congestion, perhaps a little bit of mild blunting of the left costophrenic angle. And so again, would be consistent with congestive cardiac failure. So for this chap who was presented to Cowra Hospital, they made a sensible decision in restarting his beta blockers and gave some digoxin and then a bit more digoxin to try and achieve rate control. And look, digoxin's probably a medication that's gone out of favor a little bit in the last 10 years, but I think it still has an important role to play in heart failure. Obviously, it'll help obtain rate control for atrial fibrillation, and the good thing about digoxin is it's not going to drop your blood pressure. If anything, it's a little bit of a positive inotrope as opposed to a negative inotrope. So for someone who you're concerned about their AF and wanting to avoid dropping their blood pressure, digoxin's a good choice. It's also a safe medication to use, so very reasonable decision there. The patient was then transferred across to Orange Hospital for an echocardiogram to investigate these clinical findings of congestive cardiac failure. So again, this is the echo that was done on arrival to Orange Hospital. And if anything, this echo looks even worse than our last chap. So this is the parasternal long axis view, showing the mitral valve at the bottom of the screen, the aortic valve at the top. And the left ventricle is really not contracting much at all. There's a trivial pericardial effusion just below the left ventricle there. This is the apical 4-chamber view of the heart. And again, you can see a ventricle which is barely contracting. So it's a wonder that this patient has any blood pressure at all, really. I guess different to the previous case, there's no definite LV thrombus, although we would be looking very hard for LV thrombus because with a ventricle this poor, there is a real risk of developing one. There's another view showing the poor LV function. And that's a subcostal view. So you can see the right ventricle at the top of the screen there and the left ventricle below it. And you can see that the left ventricle is really quite dilated. And it would measure, well over 5.5 centimeters in diameter, diastolic diameter. So this patient, this 48-year-old patient with severe LV dysfunction and AF with rapid ventricular rate was investigated for the cause of his cardiomyopathy in Orange Hospital. Again, we started off by doing a coronary angiogram to look for any coronary artery disease which may have contributed. Again, probably a low pretest probability for this patient. And I have chosen 2 quite young patients as opposed to, I guess, our normal population. So perhaps unsurprisingly, his coronary arteries, which is shown here in the angiogram, are normal. So we've got on the left of the screen here, a catheter sitting within the left main, injecting contrast into the left main. The circumflex artery comes down to the bottom of the screen, and the LAD runs around the top. There are some diagonal branches coming off the LAD, and you can see that the arteries are nice and smooth and of good caliber. On the right of the screen
Alex,
is the right. Yes?
Sorry to interrupt. We've just got a question from Dr. Hoyle. He's wondering if there were clinical signs of heart failure for this patient.
Yes. Yeah, so no, he did. He had, when he came across to us in Orange, he had crepitations throughout the mid to lower zones. He had some mild pedal edema. his JVP was distended. So clinically he was in heart failure. And that's the right coronary on the right of the screen there. So normal coronary arteries. So what we thought we would do for this patient with AF with rapid ventricular rate and severe global cardiomyopathy but normal coronary arteries was commence him on heart failure therapy. We swapped him from metoprolol short-acting to carvedilol, as that is one of our favoured heart failure beta blockers. And we attempted to get rate control of his atrial fibrillation using the beta blocker. We used intravenous diuretics to try and get him to a dry weight. And then we changed him over to oral furosemide and spironolactone, which is usually a good combination. And for this patient, we wondered whether his AF may have contributed to his cardiomyopathy, which is a condition called tachycardia-mediated cardiomyopathy. And we thought it's probably a good idea for this chap to try and get him back into sinus rhythm. It's always a bit hard to say with these patients because it's possible that the AF and running a fast heart rate for many months could have led to the development of a cardiomyopathy, but vice versa, if you have a dilated cardiomyopathy, then you are at risk of developing atrial fibrillation. So it's hard to say which is the chicken and which is the egg in this situation, but we do try and get these patients back to sinus rhythm because that usually helps. So in preparation for that, we started some amiodarone because we thought that would help with getting him back into rhythm. Then we booked him for a tow, which we brought him for a few days later. And this is the transesophageal echo. And the reason we do transesophageal echoes before doing a cardioversion is to look for, I mean, I guess it gives us a really good picture of the heart, allows us to better assess valvular heart disease, particularly left-sided valves. But the primary reason is to exclude any left atrial or left atrial appendage thrombus, which would be a contraindication to proceeding with cardioversion. And most of the time you don't see it, but for Mr. JC, we did see it. And this is not what you want to see when you're going in to do a cardioversion. So this is a transesophageal echo long axis view of the heart with the left ventricle here, the mitral valve opening and closing. And then above the mitral valve, you can see that kind of smoky appearance within the left atrium. We call that spontaneous echo contrast, or SEC, which is a precursor for the development of thrombus. And then just below all that spontaneous echo contrast, or almost where it's coming out of, is the left atrial appendage. And that should be black, just, you know, it should be just full of blood that moves in and out of the left atrial appendage. But you can see the left atrial appendage is chock-a-block full of thrombus, and it looks like an impending stroke, because if that dislodges, he'll be in a lot of trouble. So obviously we didn't proceed with the cardioversion. The patient had only just been recommenced on anticoagulants, and so we continued that going. We kept him in hospital for a couple of days after that stroke just to closely observe him. We didn't want to send him back to Cowra with that appearance in the left atrial appendage, because he could stroke out at any moment. So the amiodarone was ceased and a rate control strategy was adopted initially. So we discharged this patient home on apixaban, 5 milligrams twice daily. We discharged him on carvedilol, and we got him up to the maximally tolerated dose. Now, for this patient, we couldn't get him up to 25 BD because his blood pressure just wouldn't tolerate it. So we used a combination of carvedilol and digoxin to try and get that rate control that we needed without dropping his blood pressure too much. We started him on some ramipril, and I think we might have only got him up to like 1.25 or maybe 2.5 milligrams. It was quite a measly dose. And then we used a combination of furosemide and spironolactone. He was discharged home, and we arranged a cardiac MRI, which is, you know, as I was saying, more and more part of our workup of these patients. That was performed in Sydney and confirmed severe LV dysfunction. And the scan was reported to show findings that were consistent with a tachycardia-mediated cardiomyopathy. Although I think it's probably difficult, you know, to ascertain that just from the MRI scan, because I guess it could also be a dilated cardiomyopathy, which a patient has then developed AF. We then brought him back for a repeat tow 3 months later, so after giving him anticoagulants for 3 months, and thankfully that showed resolution of the LA thrombus. But we were unsuccessful at cardioverting him because we didn't have any amiodarone on board. So then we loaded him with amiodarone and brought him back for another cardioversion, and this time we were successful in restoring sinus rhythm. And I've just thought I'd show you some pictures of that subsequent toe, so that you can appreciate the improvement in LV function there. So just with rate control of the AF and getting him on some heart failure therapy, that left ventricle is now contracting better. It's probably maybe 30%, EF 30%, 25, 30%. The left atrium is still very dilated, and there's some spontaneous echo contrast, but the appendage is now free of thrombus. So we thought that was a position where we could safely cardiovert, and we did, and we're successful in restoring sinus rhythm. So the next step for these patients is more and more tending towards sending them for pulmonary vein isolation, because we think that part of the etiology of his cardiomyopathy is the AF. We want to do all we can to prevent him from having further AF. Now, you know, amiodarone's a good drug for maintenance of sinus rhythm, but it's a pretty dirty drug as well. And we're happy to use it for a month or two pre and post cardioversion, but would prefer to avoid it in the long term. So we referred this patient for a pulmonary vein isolation, which was performed down in Sydney. Following the pulmonary vein isolation, we swapped him from Ramipril over to Entresto, and 3 months after the pulmonary vein isolation, the amiodarone was ceased, and we commenced him on a heart failure specific beta blocker, being bisoprolol. And sometimes we use bisoprolol because it's a bit simpler from a dosing point of view. It's just a once daily dosing, which can be helpful, particularly if you're out on the farm. And you'll have to trust me, this one's not showing today. I think it's but the LV function at follow-up was vastly improved, and his ejection fractions back to 50%, which is tremendous for someone who started with an EF of about 15%. So from this trial, from this case study, I thought the therapy that we could discuss would be pulmonary vein isolation, because as I mentioned, I think you'll be seeing more and more of your patients being sent for pulmonary vein isolation. And I think it has a really important role to play, particularly in the management of AF in the setting of heart failure. So what is pulmonary vein isolation? Well, it's either radiofrequency or cryoablation, which is performed around the 4 pulmonary veins. And it's done by an electrophysiologist, so an EP cardiologist. EP labs are really only located in the major metropolitan centres, so there's a number of EP labs in Sydney, but not even all the private hospitals and not all the public hospitals in Sydney have the facilities to do EP studies. And so from Western New South Wales LHD, we send most of our public patients to Royal Prince Alfred Hospital, where they have a great EP department. And what they do for a PVI is they'll get your patient to have a CT scan of the heart to map out the left and right atrium, and as well as mapping out the pulmonary veins, making sure that all 4 pulmonary veins drain normally into the left atrium. And then the study is done via usually catheters from both the left and the right femoral veins, passed up to the heart. They do a transeptal puncture to cross across the interatrial septum into the left atrium from the right atrium. And then whilst they're in the left atrium, they create a map based on the CT scan, as well as some endocardial mapping, which they do in the lab to map out where the pulmonary veins are entering the left atrium. And then they start ablating, and see on the right of the screen here, each of those little red dots represents an ablation that they've performed, and they have to create that ablation in a circle around the left pulmonary veins and then around the right pulmonary veins. And they're trying to electrically isolate those pulmonary veins from the rest of the left atrium. And the reason we do that for AF is that we know that AF almost always originates from the pulmonary veins. So if you can isolate those pulmonary veins, you can prevent the AF from escaping into the rest of the heart, and you can help maintain sinus rhythm. So this therapy has been around for a little while, but has become increasingly popular over the last 5 years, I'd say. And the pivotal trial, I think, for pulmonary vein isolation in the setting of heart failure was the Castle AF trial, which was published in NEJM in 2018. And that's a study of 398 patients with symptomatic paroxysmal or persistent AF, who had NYHA class 2 to 4 heart failure and an ejection fraction of 35% or less, who had failed therapy on antiarrhythmic drugs. The intervention in this study was pulmonary vein isolation, and the comparator was medical therapy with either rate or rhythm control, although rhythm control was favoured by the study designers. And this trial actually had every patient in the trial had a defibrillator implanted, because as you can see from that inclusion criteria, they're also the inclusion criteria for patients who would be recommended to have an AICD for primary prophylaxis. And so having an AICD in situ meant that the study was able to monitor very closely for any recurrence of AF. Yeah, so that it was a really well-designed trial. The primary outcome of the trial was a composite of death or from any cause or heart failure hospitalizations. And at a median follow-up of 37 months, the primary outcome occurred in 28% of the PVI group compared to 44% in the control group. So it has a ratio of 0.62, clearly favouring pulmonary vein isolation in this patient population. So what do I think you should know about pulmonary vein isolation? Well, in terms of anticoagulation, everyone gets it for at least 3 months after a pulmonary vein isolation. If you do that ablation within the left atrium, you cause a lot of stunning, and there's a real risk of thrombus formation. So for at least the first 3 months after pulmonary vein isolation, the patients will be on anticoagulants. And then long term, the decision about anticoagulants in these patients depends on what their pre-existing CHADS-VASc score was. And the reason we just base it on the CHADS-VASc score is that whilst this is a good therapy, its success rates, only 80% success even in the best patient, the best selected patient for this kind of procedure. So there's a 20% risk of procedural failure, and for that reason, we base our decision about long-term anticoagulation on their CHADS-VASc score. And so if their CHADS-VASc score is 2 or more, then we would recommend anticoagulation. 0 probably would recommend against it, and if it's 1, you could go either way. Who are we sending for pulmonary vein isolation? Certainly younger patients, so patients less than 65. We would definitely consider pulmonary vein isolation in the setting of heart failure. But we would even include them out to 75 years of age, maybe even 80 at a push, depending on their comorbidities. And I think you'll find that pulmonary vein isolation, whilst it's obviously a cornerstone of treatment for AF and heart failure, is becoming more and more prevalently used for AF in general, because you'll find a lot of patients with AF either have treatment failure with antiarrhythmic drugs or are intolerant of the antiarrhythmic drugs. And both those would be reasonable indications to recommend a pulmonary vein isolation if you're hoping to maintain sinus rhythm for your patients. So that brings me to the end of my talk. I'm happy to take any questions on the cases that we've discussed or the therapies that we've gone through. And then I've got one more slide as a bit of an update on the provision of cardiac services across Western New South Wales, which is kind of separate to the rest of the talk.
If anyone has questions, just use the questions box to type in there. We've got a question from Station. The mechanism of action for Dapagliflozin in heart failure?
Yeah, it's a good question. So obviously the SGLT2 inhibitors act as a bit of a diuretic, and that's postulated as potentially part of the reason why these medications might have a beneficial effect in heart failure, because they add a bit of diuresis. But that's, I guess, the only cardiac specific effect of the SGLT2 inhibitors that I'm aware of. I'd have to read up and see if there are any other, vasodilatory or anti-fibrotic effects of these medications, but certainly the diuretic effect is favoured.
A question from Anna, and I hope I've got this right. Anna, are there any updates on management of heart failure with preserved ejection fraction?
Yeah, look, it's less of a satisfying topic, heart failure with preserved ejection fraction, because our treatments are a lot more limited in that realm. I think really for the management of heart failure with preserved ejection fraction, the cornerstone of treatment remains diuretics. There's less evidence for ACE inhibitors or beta blockers in that condition. Diuretics really for relief of symptoms and pulmonary venous congestion. And then our focus is really on optimizing the causal factors for heart failure with preserved ejection fraction. So getting really good control of blood pressure, because we know that hypertension and left ventricular hypertrophy are a real risk for the development of heart failure with preserved ejection fraction. We screen for other conditions like obstructive sleep apnea, which would be a contributor to HFpEF. Optimization of diabetes management is really important as well. And then, looking at non-pharmacological lifestyle factors like weight loss and cardiorespiratory exercise training are also really important. But less available for our therapeutic armamentarium for HFpEF.
Got a thank you to you for a great presentation, Alex, and a question as well from Martin. Are there particular things that you really want GPs to be doing with CCF patients?
Well, thanks, Martin. Look, I guess from our side of things, as it stands in the district, it's obviously hard to follow up all these patients. So I think we really do rely on our colleagues in general practice to help with the up titration of heart failure therapies. And I think if you have an understanding of the therapies that we're predominantly using now, and then our goal is to try and maximize those dosing. That would be the first point. So, up titrating doses of beta blockers, ACE inhibitors, making sure that we're achieving a euvolemic status for these patients with the aid of the diuretics. And then, the things that we try and hammer home to our patients when we catch up with them is things like fluid restrictions. So somewhere between a 1.2 and a 1.5 litre fluid restriction, trying to minimize salt intake in diets. And I think it's really, if you can empower the patient, so if they can monitor their own weight and record that and, really keep an eye out for their symptoms, then they can really make adjustments to their therapy as well. So, if a patient's noticing that their weight's increasing by 2 or 3 kilos in a couple of days, that's going to be fluid overload. And so in certain patients, you can really get them to up titrate their furosemide if required, and then closely follow up with the general practitioner. So they're the kind of management strategies that we would be hoping that GPs could help with as well.
Another question now from Greg. Does glucagon play any role in these days in beta blocker overdose as pertaining to case 1?
I believe so, Greg, but to be honest, I haven't seen a beta blocker overdose often. In terms of case 1, we didn't use glucagon for that case. We were able to reverse things with just the beta agonist. But I guess probably the intensive care team would have more familiarity with what they use in beta blocker overdose. I guess if the dobutamine didn't work, I would have been going straight to up to date and having a look. But from memory, I think they do use glucagon in that setting.
A question from Dr. Fox. In terms of managing heart failure with preserved ejection fraction, how should GPs approach this diagnosis? Should we be looking for subtle things in echo reports?
Absolutely. Thanks, Catherine. So look, heart failure with preserved ejection fraction is diagnosed when there's clinical signs of heart failure, plus echo features of heart failure with preserved ejection fraction. And also we can check BNP levels, so NT-proBNP levels, which would be elevated in heart failure. In terms of the echo features that are suggestive of diastolic dysfunction, so first and foremost, you'd be looking at the ejection fraction. So if the ejection fraction is reduced, then it's going to be systolic heart failure. But if you've got a normal ejection fraction, which would be greater than 55%, the things that I'm looking for when I'm diagnosing heart failure with preserved ejection fraction are firstly, what's the size of the left atrium? So for heart failure with preserved ejection fraction, the left atrium is usually dilated. There's usually left ventricular hypertrophy, although not always. And then there are some parameters that we look for to do with the mitral inflow, which are Doppler parameters. And it gets a little bit kind of complicated. We'd have to kind of hash it out on a piece of paper, but you can look at the way that the pattern of the passive filling of the left ventricle compared to the active filling from the atrial contraction, and you can look at differences in those numbers to make the diagnosis. So I guess in terms of echo reporting, what I try and do, if the echo request says query CCF or heart failure or breathlessness, and there's normal systolic function, I'd usually try and report whether there's normal or abnormal diastology. But if that's not reported, the clues that would suggest abnormal diastology that I think you guys could pick up would be first and foremost a dilated left atrium. And then if there's a bit of LVH there, then that would push you towards diastolic dysfunction, although and then the other parameters I think are a little bit tricky and may or may not be reported depending on who's doing the reporting. But the other thing that you could look at apart from the echo would be the NT-proBNP level.
We've got a question from Ari. Could you comment on sequential diuretics use in diuretic-resistant CCF patients?
Yeah, no problem. So look, to be honest, I'll try and keep it pretty simple. With heart failure with reduced ejection fraction, we know that there's a mortality benefit for mineralocorticoid receptor antagonists. So I would try and get a bit of spironolactone on board. Some patients with spironolactone will develop painful gynecomastia, and in that patient population, I'd use eplerenone, although it is more expensive to purchase. Loop diuretics remain the cornerstone of fluid balance management. So if there's evidence of fluid overload, despite being on a small dose of spironolactone, then I would use a loop diuretic. A lot of people would go with the loop diuretic first and then add spironolactone as a second point of call. I think that's also reasonable. I would be hesitant to add more than 2 diuretics at a time though, because I think that's where you're going to really develop renal impairment, hyponatremia. So I'd be hesitant to go to a 3rd diuretic, although occasionally we'll use moduretic. And in one instance in the last couple of years, I can remember using a loop diuretic, a thiazide diuretic, and spironolactone. But I think, we feel a little bit more confident doing that in hospital because you can check their EUCs every day. And I think before going to a 3rd diuretic as an outpatient, I'd be looking at admitting them to hospital and using intravenous agents. And quite often we find that, for these patients, we might be hitting them hard with ADBD or furosemide plus the maximally tolerated dose of spironolactone as an outpatient. You're just not making any inroads to their significant heart failure. And then you bring them into hospital and you put them on an IV furosemide infusion and stop the spironolactone, and their heart failure improves dramatically. And I think that's because when you've got these patients with severe heart failure, they've got edema not only of their lower limbs but also of their gut, and I just don't think they're absorbing their diuretics that well. And so quite often we find that swapping over to intravenous agents, and I guess that's possible through hospital in the home as well, as another alternative.
Got a question from Pip. Over what period of time can tachycardia-mediated cardiomyopathy develop?
Yeah, good question. Look, to be honest, Pip, I'm not sure. The second patient from today's kind of discussion had it for 6 weeks, and that was enough for him to develop a tachycardia-mediated cardiomyopathy. I think it would probably be a month or two would be likely. I'd be very surprised if it developed any shorter than that, and I can't think of from the patients who we've treated for tachycardia-mediated cardiomyopathy, anyone presenting shorter than that. Although I would say that quite often these patients are asymptomatic of the atrial fibrillation and really only present when they develop symptomatic heart failure. So often it's quite hard to know how long they've had their AF for. It could have been months or even a year, and they only really present when they develop symptoms of heart failure.
We've got a comment from Jenna, which might be helpful for people using hospital in the home for home monitoring of patients to monitor their weight, BP, heart rate could be beneficial post-discharge. Just something else to think about.
For sure.
That's all that we have for questions, Alex.
Well, terrific. Well, I might just spend 2 minutes if I can, or just a minute, just kind of giving people an update, because I'm sure people are interested in what's happening across the health district in terms of cardiovascular services, because there's been a lot of changes. So within our LHD, Orange continues to provide the 24/7 cardiology consult service as well as AMI management, and we'll continue doing so for the foreseeable future. Obviously, we have a 24/7 cath lab and can provide PCI services at any stage. The really good news in the landscape is that Dubbo has now commissioned their cath lab and are planning to commence diagnostic angiography services by the end of this year. To do so, they will likely be recruiting a new cardiologist to Dubbo because they'll need some more workforce to be able to man that lab. And I think that'll be really important, because I know that it's been a real battle to get people seen by cardiology across the district, but particularly in Dubbo, where there's a huge need, and only Kanishka, Kalamidasa and Tilak Sirasena up at the hospital who are doing all they can, but are drowning a bit at the moment. So I think if they can get another cardiologist or two up at Dubbo-based hospital, that'll be terrific and really help to alleviate some of that wait time that's built up. Here in Orange, as many of you would know, the Dudley Hospital has opened a cath lab, and we've started doing some cardiac procedures there this year, which has been good. For the first year after you open a cath lab, you can only do diagnostic angiograms, so there's not many cases being done there at present, but it does allow us to do some transesophageal echoes and DC cardioversions at Dudley, which has been helpful in alleviating some of the wait time for the base hospital here, which continues to be the backbone of the cardiac services across the district. What I think you would have both seen in both the cases today is the utility of cardiac MRI, and we're using it more and more these days. And one of the really good things to happen in the last 6 months has been that Orange has upgraded its MRI machine, and now it's enabled us to do cardiac MRI studies. And so we're trying to buddy up with some cardiac MRI specialists from Sydney to help report those studies, which would be really helpful in giving our patients better access to this important imaging modality. And then the light at the end of the tunnel for us here in Orange is that one of our registrars, Samir Kave, will be coming back to join us as a full-time cardiologist from early next year. He's already been appointed to the LHD and is doing some regular work for us this year, but is completing a fellowship in imaging in Sydney, and will be joining us full-time out here next year, which will be great to try and get through some of our outpatient wait times, which are just have blown out at the moment. So yeah, there's some light at the end of the tunnel, and hopefully some more help arriving soon.
Thank you so much, Alex, for presenting for us tonight. We will just try and get an evaluation slide up on the screen for people to use their phones to scan the QR. If you could do a survey for us of tonight's presentation, that'd be great. But thank you so much, Alex, for your time and a great presentation. There's lots of thank yous coming through.
Okay. Cheers.
Great presentation. Thanks so much. Thank you, everyone. An evaluation link will go out by email as well. So have a good night. Thanks for joining us tonight, and we'll see you next time. Thank you, Alex.
Thanks. Bye.
Bye.